So our next speaker would be Dr. Tae Sok Kun. He or she's currently a head of the Genetic and Metabolism Unit, Department of Pediatrics. So don't be uh, don't be uh, don't be alarmed by the pediatrics, because we do work very well as an adult as well. So we send a lot of adult patients to Dr. Tae regarding genetic diseases and potential of, family history and so on and so forth. So she's going to give a talk entitled Genetic and Genomic Testing in Nephrology, Advances, Challenges, and Clinical Insights. The floor is yours, Dr. Tae.
Thank you, Professor Hafiz, for your kind introduction. I hope everyone see my slide clearly. So, thank you for the invitations, and again, happy World Kidney Days. So today, just a little bit sharing on the genetic and genomic testing in nephrology. What is the current advances? What are the challenges Malaysia are facing or we are facing? And how do we use it in the clinical insight? I will, of course, cover what is the role of genetic testing in CKD, the type of genetic testing, focusing on CKD, the do and don'ts of genetic testing, using a few cases to highlight what is the importance of genetic counseling, what is the possible outcomes that we might get from a genetic testing, including variant of uncertain significance, secondary findings, especially when we are doing more and more comprehensive genomic testing, and of course, the importance of ethical and legal perspective behind each genetic testing, the challenges that we are currently facing and way to move forward. And chronic kidney disease actually poses a very significant health and economic burdens, as mentioned by Professor Hafiz earlier on. It is even more prevalent than diabetes. And the advancement in genomic sequencing, especially next generation sequencing or the massive parallel sequencing, actually caused a lot of opportunity in clinical field, where it lead to a rapid advances for us to understand what is the basic of the genetic or molecular level of certain diseases, and thus help us in terms of clinical trial and new therapy. Way back in, I think, March 2021, where KDIGO actually have a controversies conference focusing on genetic in chronic kidney disease, that they actually recommends all the physicians or to think genetic. We're focusing on four main aspects in detail: obtaining detailed family history, getting a complete history on the age of onset, examination of extravenous symptoms, as well as consider genetic testing in assessing and managing the patient. So the clinical utility, of course, as mentioned by Prof. Camilla earlier, but additional of that, beside ending a diagnostic odyssey, change in treatment and management plan, but more importantly is also it helps to inform prognosis and guide in the genetic counseling, especially reproductive counseling, where nowadays we actually could do the pre-implantations as well as prenatal genetic testing. To understand more on the family planning part of it, as well as evaluation of the living kidney donors. Of course, it will also provide information for others at-risk family members to do an early screening, early detection, following the theme of this year World Kidney Disease Day, that prevention and early detection. So look into the studies done by Dahl et al. In 2023. They actually looking into a cohort of 1,600 plus patient, that using a gene panel of 385 renal gene panel, that from there the diagnostic yield is roughly about 20.8%, and you can see that actually up to 90.7% achieve any of the management change, including early surveillance, including family plannings, and so on and so forth, and up to about 32.9% for those that having management change actually receive a treatment change. So we know that genetic testing is not only to aid in diagnostics, but also management nowadays. Before we move on further, just a little bit of to clear everyone's minds that we are looking into a spectrum of disease for CKD. Back in the monogenic, where we are talking about a single gene diseases with rare variant, a very strong genotype-phenotype relationship, where the environment factor have limited influence, and usually they are of Mendelian's inheritance. For example, the ADPKD, the Alports that mentioned earlier, and to a very complex or polygenic disease, where usually involve common variant with a low penetrance, or rather we say treat. For example, the EGFR that is affecting the certain allele, where the environmental factor actually have a very strong influence and the inheritance is not very apparent here. And I always see this thing as a spectrum instead of two very distinct entity, because there is always a group of rare variant in a few genes that we call that polygenic conditions. For example, like this APOL1 gene, especially in HIV patients, that with the presence of the risk allele, then they have higher risk of getting nephropathy, as well as this PLA2R1 gene, where it is known to have increased risk for membranous nephropathy. But it is not just like a single gene changes. But for today, I'm just going to focus more on the monogenic condition first. And up to date, we identify of more than 600 genes that is implicated for chronic kidney disease. And looking into the pediatric cohort, it contributes up to about 50% of the non-diabetic CKD. And it is not that rare even in adult cohort, where it contributes about 10 to 30% of adult cohort. And what kind of patients, or what will be the patient selection that is more suitable for genetic testing? Of course, the young age of onset will give you a higher yield with a strong family history. A cystic or anatomical abnormalities like could or multiple cysts could yield a higher positive diagnostic yield as well, or a CKD of unclear etiology, as well as those with extrarenal manifestation, for example, like hearing loss. And more actionable gene in kidney disease has been identified. What will we mean by actionable gene means certain condition that we identify and there will be a change of management or treatment or even surveillance. For example, of course, Fabry that we know nowadays, we have enzyme replacement therapy. But even for Alport, we do not have specific therapy, but there is the condition that is amendable by non-specific but renoprotective strategy so that we can avoid prolonged immunosuppressive therapy. Last but not least, I would like to also highlight the importance of nowadays, we could actually do a prenatal or pre-implantation diagnosis, especially for preventive purposes. Before we move on to talk more on the genetic testing, just a very basic concept so that we understand more on what are we talking about of all this type of genetic testing. If we imagine our genetic makeup is like a book, a recipe book maybe, then our mom will give us half the volume of the books, and dad will give us half the volume of the book. And we all know that we have 46 chromosomes, so that is like a chapter of the book. And when we keep talking about gene, and that is like a pages of the books with informations and specific recipes. For example, the recipes that is making the red kidney, the recipes that is making the bone, and so on and so forth. And each of the ACTG, the bases that we know is like the alphabet, that all three will form a codon or words. So any changes in this spelling mistake or any deletion or duplication, we call that a variant. Multi-genes panel, just like I mentioned earlier in that study, just they collectively pick up a few of the gene, like for example, just now 385 gene, and then identify and read those genes spelling. And what about whole exome and whole genome sequencing that is getting more and more attention nowadays? So we have roughly about 20,000 genes in our body. Exome is solely means that the area with information that we can transcribe then become a protein. Where intron, even though that is not transcribed to the protein, so it is like the blank page or blank space in a recipe, but sometimes it do affect the expression of the exon. So whole exon by the name, meaning they take out all the exonic region and read it, whereas the whole genome, they read it inclusive of the intronic region. If we are imaging now, just now a book, right? Now apple pula. If we are imaging that our genome like an apple, the exonic area when we take cumulatively all is just roughly about 1 to 2% of our whole genome. So even though the name of whole there, I hope now we understand more or less that it doesn't really mean whole. Our genomic is way more complex than that. So what about the diagnostic yield? If we are looking into gene panel alone, so this is another study looking into 1,000 participants using a 382 gene panel, the yield is roughly about 21.1%. So it is roughly comparable with the previous study. Whereas when people looking into exome sequencing, The yield is roughly about 36.5% in adult and 41.6% in children. Later, I will share the experience of our center as well. And there is a study that actually recommend why not we do a whole genome. Then, as I said just now, each exome is just about 1 to 2% of the genome. Then the yield is increased, but not so much if you compare to about 41% in a pediatric age group. So then now we also need to take into consideration the cost effectiveness of it. Of course, the whole genome, just now, to answer the question, I said that the exome is roughly about 1,000 to 2,000 ringgit, but genome is way much expensive, up to about 5,000. Earlier on, I think like when we first started doing genome sequencing, it is actually up to about 35K ringgit Malaysia, of course. So how about our experience? So when we look back about 6 to 7 years of our cohort, nephrology actually consists, the yield is roughly about 35%. Of course, our cohort is very small, and this is inclusive of both pediatric and adult patient. And if we're looking into the age group of those that we are seeing, of course, this is only about 23 patients. The pediatric yield consists of higher, about 65%, 15 of the pediatric patient and about 8 of the adult patient. But having said that, the yield is more or less the same. So what is more important than the genetic testing? Of course, the genetic counseling. So pre-test and post-test, we will need to do thorough counseling. So pre-test counseling of including what we need to tell the parents or patients, what is the indication for the test? Because very often they will think that, oh, you're doing some research, because genetic to them sounds like very fancy. So we should also aware about what is the potential outcome. I will use a few cases to make all of us understand better. In terms of the outcome of pathogenic, benign or negative, and variant of uncertain significance. And if there is negative testing, what will be the causes of undiagnosed condition? They need to know beforehand, so that they could actually prepare and be informed and make an informed decision. And of course, the impact to the insurance, the secondary or incidental finding, they have autonomy to withdraw from the test anytime, and whether or not they would like to share the result with others family members, because this really, I see that is a stigma in our community. And about post-test, of course, not only to inform the result, but also to provide psychological support. So just a little bit on how do we interpret those variants. As we all know, the genetic, there is no gold standard, or not like any other test with a normal range, or like, for example, we know what is normal, because everyone have a different genetic makeup, and I couldn't say that, oh, you didn't follow my genetic makeup and thus yours is wrong. No such thing. So we mainly focusing on these 4 aspects: the gene disease association, the phenotype concordance, whether or not it fits our phenotype, the variant level of evidence based mainly on these 7 data that I mentioned here: population data, segregation data, and so on and so forth. And of course, the disease mechanism, because not all disease is caused by loss of function, but some is caused by a gain of function. So putting all this together, we then will put in this chart, ACMG guidelines, where this how, so that everyone kind of interpret the variant with a standard way. And how do we then, after we interpret this variant, we categorize them into these 5 category: pathogenic, likely pathogenic, uncertain significant, likely benign, and benign. Of course, for clinical use, pathogenic and likely pathogenic will categorize and use, we treat them as same one. Vice versa, the likely benign and benign. But the uncertainty is always the variant that is causing a lot of headache. Then they will subdivide into 3A, B, C, or even some say hot, warm, cold, or some use color, red, yellow, and green, but all means the same. Which one is more likely to be able to upgrade to be pathogenic, and which one will be more likely to be downgraded to benign? So let's share a few cases so that we kind of gauge what is all these variants mean. So I have a 20 years old gentleman, HE here, who started to have periodic paralysis at 10 years old. And at 13 years old, during one of the episodes, there is a very bad hypokalemia, required IV correction. And subsequently, she was admitted, I think, more than 5 times a year with frequent hypokalemia episodes and paralysis. And with that, even though on a very high dose oral supplement, the symptoms do persist. that make him actually have a lot of trouble. And he also was diagnosed with hypothyroid with Hashimoto thyroiditis. Otherwise, BP was normal. There is no other significant family history. Was extensively investigated for metabolic acidosis with hypo-K and hypomagnesemia only in one of the episodes. Initially treated as ketamine, but the metabolic acidosis and hypomagnesemia resolved after the one episode, but the hypokalemia remained and worsening. So she came to us with a lot of frustration, and then we proceed thinking about channelopathy and proceed with a singleton's exome sequencing, and we found this CACN1S gene that is pathogenic. Heterogeneous means only one allele is affected, and this will lead to a hypokalemic periodic paralysis type 1. So now we end the diagnostic odyssey after 10 years, and he eventually know what is the diagnosis. We didn't proceed with parental testing here, and thus we are not sure whether is this variant de novo means happened for the first time in him himself, or it is actually inheritance. But this actually lead to treatment and management change, where now he know that high carbohydrate food will trigger him, so he try to avoid that, and he have a better ideas on the recurrent risk. And he is now actually a medical student, and he even started to discuss on the reproductive care with us now. So the second case, 42 years old gentleman, initially referred for workup for renal transplant, diagnosed to have CKD stage 4 in 2022 during company physical body checkup, and has been comments on hemodialysis started then. But went for the history, he actually had young hypertension way back in the secondary school time on antihypertensive since 30 years old, but not on proper follow-up. Otherwise, there is no significant family history, and this is the ultrasound show. Multiple polycystic. Of course, then the managed team sent on a commercial multi-gene panel, looking into the cystic kidney disease panel, focusing, they are thinking about their working diagnosis is ADPKD, so 44 gene. So everything fits nicely, but if you look closely into the 44 genes that is in the commercial panel, there is actually lack of a PKD1 gene, which contribute to 78% of the ATPKD. So I just want to highlight here is because this is not only the first case, but a lot of physicians do only look into the panel name and then thought that, oh, it should include all the gene, all so-called the gene that is responsible, but it is not in the case, especially for commercial panel, because most often they will actually put in the panel. Of course, they calculate all the ROI and so on and so forth. But the other thing is also we frequently and constantly curate the gene. So not only the variant, but we also curate the gene to see that which gene is actually causing certain disease. We call that a gene disease correlation. So things keep changing. What is the clinical utility of a genetic test in this particular patient? You might think, because patients always frequently think because you want to do some research. Not really. It helps to prognosticate, of course, whether PKD1 or PKD2 and the different variant will tell us how serious it is, because there is phenotypical correlation by gene itself and genotype-phenotype correlation, where we know a truncated variant actually could cause a more severe disease. Of course, it's important for subsequent family cascade screening, because this is an AD condition, and for reproductive and prenatal care, as I mentioned earlier. But in this particular patient, it's actually because of the liver transplant. So we are doing an evaluation for living kidney donors. And what happened is the sister, which is potential donors, actually was screened via ultrasound, also having a simple cyst. So now everyone was in dilemma. So should we proceed to do this something that is involving the PKD1 or not? So then we actually proceed in order to clear everyone's mind. But unfortunately, this is a variant of uncertain significance. So variant of uncertain significance is not a diagnosis. We cannot overrate, respond or overrate it. Of course, people will say, just assume lah, then we do a family screening for that. Unfortunately, we can't. But this particular variant will be able to upgrade if we confirm that it is de novo. So parental testing help. Unfortunately, the parents passed away for this patient, and we do not able to prove that. And now looking at the sister is a potential donor, one of the way, but not the best way, we actually do the similar variant in a sister and noted that it's not observed. this is not like completely right, but this is something like we can't do anything better than that. So at least we know that it's not present in the sister. And of course, then people say, can we test the sister alone for the genetic testing? The answer is no, because how do we read? Like earlier on, I mentioned we need all those criteria to read it. So it is not a screening test, and we can't use that as a screening test per se. So variant of uncertain significance just tell you that I don't know whether it caused a disease or just a normal variant because limited data, complex genetics, and it could be a newly discovered gene or variant. So don't overinterpret, and it is not a diagnosis. So you can't use that as a medical decision. But of course, just now we use it with very much consideration and an MDT discussion. So variant of uncertain significance, because our variants frequently changes, even a likely pathogenic or pathogenic will then change the VUSs. So it is a dynamic process instead of what we think of other testing that is very static. So the recommendation after we look into this very large cohort of variants is that is 20% of variant benefit for reassessment. All the patient age group benefit for reanalysis, and it should be done about 1 to 2 yearly. Do not need to always keep sequencing. Reannotation will do. But if the NGS data is very outdated, then we might need to resequence because the outdated one might have less coverage. Finally, case 3, a 12 years old boy diagnosed to have steroid sensitive nephrotic at 2 years old, unfortunately frequent relapses and subsequently steroid resistant with hypertension, started off cyclosporine, and ultrasound show renal parenchyma disease, renal biopsy show diffuse mesangial sclerosis, renal function is still normal, was referred for further investigation of steroid resistant nephrotic. And if we look into the flow chart, that this will be the gene of interest following the clinical findings. And we proceed with exome sequencing, focusing on the gene of the interest in particular. It is a negative result. Here, we need to tell the parents from the very beginning because very often after the negative result, the parents will then default all the follow-up and say, yes, she is normal or she is normal. So this is not the case, that we need to beforehand tell them negative just solely mean from the technique or whatever test we do, we didn't identify any pathogenic variant, but the disease, we already know the steroid-resistant nephrotic syndrome is always there. So what will be the causes? It could be either really non-genetic, polygenic, like mentioned earlier. There is no test, no one test that is good to detect a polygenic for the moment. We don't know in the future. The causative gene is not known yet, maybe a new gene. If this is an imprinting disorder, which is epigenetic, and other technical area. For example, just now, because I say that sequencing is reading the alphabet one by one, but what if this is a very huge deletion or duplication, then it will consider that as normal because they can't read it. And of course, triple nucleotide means the thing keep repeating, then they can't read it as well. Or the intronic region, but this one will be able to pick up when whole genome sequencing. So unfortunately, then beside what we want to know, we also notice because we do a very comprehensive test, now the BRCA2 is pathogenic. So she will have 8 to 9 times higher risk of developing breast cancer. So very often we forgot or we didn't even tell the patients about all this, and we received the only way back, there is something, and I don't know what to tell to the parents after they do all the testing. So that's why I said the pre-testing counseling is very important. And here, secondary or incidental findings solely, it will really depends on each lab. They will have different reporting system, but mainly if the lab is following, is a CAP accredited lab and following the ACMG guideline. Nowadays, there is about 81 gene that is medically actionable that we need to be reporting. But of course, we need to inform the patients about that because there is a lot of ethical issue way behind it, the anxiety that causing, like in this boy. This doesn't mean that he will get cancer now and then, but the higher risk. And also the discrimination in terms of insurance and with limited resources, let's say if it's a cardiac gene, that we identify who is going to do the surveillance. And ethical and legal consideration is very important, that we need to make them understand that this is actually a non-directive and we need to respect their choice and autonomy. Even though a lot of time we say it is benefit for you, but I recently have a patient told me that the things that hold her for hold her on to do a testing is not the cost, but the various uncertainties that she cannot cope. So sometimes we are not sure, but we need to make them understand all the benefits and pros and cons and implication, and make them do a informed decision rather than we just say, oh, this is good, or just do the test first and think later. That's obviously not the way. And the potential discrimination really is because we do not have a legal protection like what US have, the Genetic Informative Non-Discrimination Act, or even Singapore, they have a moratorium on genetic testing and insurance where they are protected. So the don't obviously is don't do it without a genetic counseling, don't do the test by pressuring the family, but because they have autonomy, it's informed decision. Don't overtreat or downplay the VUSs. Emotional impact is important, and don't overlook on the confidentiality because they own their own genetic data. What is challenges we face? Of course, limited access, cost. Every time I receive a phone call, it will be cost. There is limited labs in Malaysia that is doing all the genetic testing. But if we look into the NIH report in 2022, that the genome cost is actually coming down from last time 100,000 K to now less than 1,000 K. Of course, the cost will continue come down according to this Murray law if there is more and more people are doing it. But beside that, I hope after this whole long sharing, we understand that it's not only the cost that matters. There's also lack of awareness and understanding, not only patients, but also physicians of the importance of tests and the counseling. Of course, shortage of expertise. We only have less than 20 geneticists around the country and a handful of genetic counselor. We have one in UM with us. Ethical and cultural consideration is something that we are different and unique. Sometimes we tend to overlook that. And of course, lack of governance and national guidelines. In 2019, we actually have this guideline with ethical provisions of genetic service in Malaysia, but we do not have a very specific guideline, for example, genetic testing in CKD to make a proper flow and everyone is like on the same page on how should we proceed with the testing. Of course, not only about challenges, we always need to have hope. What should we, moving forwards, what should we do? Of course, expand access. So a lot of study actually look into the cost effectiveness of the genetic testing and whether is that really just something in the textbooks or really the utility is so important. So this Australian group actually looking into it, and they conclude that the early exome rather than just a gene panel actually help, and the cost analysis show a benefit cost analysis. However, is this model strict in our country? We actually really need to have look into it because we do not run the test ourselves but outsource. But of course, with in-house testing, then we can customize it, then it will be more useful. We need to strengthen our local genetic testing facilities. And meanwhile, while we are talking all that, I think a clear diagnostic workflow that makes sure nationwide we are on the same page and the proper referring pathway will be more useful. It's like a short-term first step that we can do a small step first, and maybe we could collaborate and find some subsidized and funding specifically for tests in nephrology maybe. And what else? Of course, the enhancing education, because with the limited numbers of GCs and geneticists around, are we able to do it? So then this is not apparently not only the problems in our country, but also a lot of other countries. So a lot of people then looking into the mainstreaming. So this is a study done on ADPKD on mainstreaming. Of course, they show that it can reduce the waiting time, but having said that, they have access with their local lab and the funding from the government. So where are we now? I think specialty specific genomic education is important. When I'm in Melbourne, BCGS, I'm running the genomic courses with Melbourne Genomic, where they actually have a specialty specific, for example, like endocrine genomic education, genomic education. I have an opportunity to involve in one of their module in nephrology. looking into the clinic nephrology, where we then running a online module and a workshop to strengthen that. So I think that might be a possible first step that we could do in our country as well. Of course, strengthening the genetic counseling service and accreditation is very important. We have a master program for genetic counselor in UKM. However, we have problem running the accredited. For example, I mentioned like Miss Rifhan is our the only genetic counselor in UMMC. I am actually, she is actually holding a scientific officer post. So we do not actually have a post for a genetic counselor per se. So accreditation and make them into create them a post is really very important and the way to look forward. So I would like to just end undeniable genomic testing now play an important role in nephrology. And I hope after this, you all agree with me that it's really beyond which lab and what is the cost, because it's more than that. And genetic counseling is definitely a very crucial point. And when we talk about mainstreaming, interpretation and understanding of the genetic testing, and understand its limitation and what is the negative result means is also important. Not to forget the ethical and legal perspective in the genetic testing. And with challenges, I hope that we just need to be persistent and take small steps at a time. And I think we will be able to move forwards. Thank you so much for your time. And I'm happy to
Right,
take
thank you very much,
questions
Dr.
if there's
Tae.
still time.
We have a couple of minutes more, so I'll get it on to Dr. Prof. Lim Sok Kun. So also, like I said, in nephrology, we also have a interest in nephrology, like they call it nephrogenetics. So can we train nephrology to be good at genetics, and so that they can do a basic understanding or counseling to the patient?
So like I mentioned just now, the way to go actually really the mainstreaming, but we need to have the education and module, so that, for example, like we are actually doing and collaborate with Prof. Aisha in breast surgeon, that we are doing a mainstreaming in oncology and breast cancer now. So we can do something similar, the module, and have some accreditation, or I don't see that if just a simple certificate kind of thing, so that people are more aware and understand on the what is implication and how to interpret the testing, so that um they know when to refer. So with that limited, like you mentioned, limited genetic counselor and geneticist, I think that will be the way to go.
Okay. How much is the education, postgraduate and undergraduate, incorporating genetic knowledge, as far as you know?
Our undergraduate, we actually try to put in some, and surprisingly, I think recently I have an elective student from Oxford, and he said that actually they don't even have any in during their undergraduate, so they can join a few of our lecture. We try to make our undergraduate student understand, but not many. We hope to increase that part also. As for postgraduate, unfortunately, only those that come to the pediatric. I mean, only the pediatric master have a chance, but we do take in attachment. Recently we have the ONG, or rather fetal maternal specialist that come to our unit for attachment, because she is doing some diploma in genetic counseling. So part and parcel, but I foresee if we could have a better education or training module, then there will be a better way to go in future.
Great. Looking forward to that. And my last question, Prof. Lim's question, any local capacity to perform genetic testing? And on the top of it, is it better to do whole exome sequencing, since that, that covers a lot more, instead of just doing all these multi-gene panel, since the price is not too high?
Okay, I will take the second part of the answer first, the exome sequencing. Of course, if you compare, that's why people then started to say we should do an early exome sequencing rather than just a panel. But bear in mind that most of the study, that when they look into cost effectiveness, right, they have that in-house lab capacity. So what we are doing actually is we sequence, because the sequencing cost is the same. So we sequence the whole exome, but when we interpret, we actually incorporate not the commercial panel, but the custom-made panel in the filter to read it. So then we actually, that's why the working diagnosis is important. It is really not the clinical geneticist that can determine, but we need all the expertise, especially from the nephrologist, to tell us what are you looking into, and so that we can then look into the disease mechanism and the coverage. Because when we talk about exome or genome sequencing, actually we also need to look for what are we looking into. For example, the ADPKD, the PKD1 is a um, uh, very naughty gene. They have a very huge similar, we call that a pseudo gene. So if we only do an exome sequencing in that, we might not pick that up, but we need to really focusing on that specific gene to look into it. Of course, the other case, we are using exome sequencing, but having said that, we actually liaise with the lab to ask them to specifically look into the copy number variant in this specific gene. So yeah, the way to go, I would still say, is really depends on the diagnosis. And then, sorry, the first part of the question is how, Prof.
Local
Hafiz, could you
capacity.
remind me the first part? Local
The
capacity.
local capacity to do.
Yeah, yeah. So for the moment, we actually would really looking into the interest to establish our own local capacity, because I foresee outsourcing is not a, definitely not a long-term plan. But in order to establish the local capacity, we need to have accreditation, what we call the CAP accreditation specifically. So I think it is possible, but not in a very short term. I
Okay.
hope that
I
answered your
have two more, but it's okay. Time is limited. It's okay. I can see you directly and ask my questions. With that, thank you very much. So let's thanks Dr. Tae and Prof. Kamila for their wonderful talk, and happy working day, everybody, for tomorrow. With that, thank you very much and happy Ramadan. Thank you.